based on this books. NCCN Guidelines 2018, Shackelford 8th edition, Levin Bailey 20th edition, Sebastian 21st edition, and Anderson Surgical Oncology 6th edition. Okay, so most of the talks what I'm going to give now are basically meant on recent advances or recent guidelines. Okay, my talk will be divided into three sections. I'll be talking on first, I'll be talking about rectum, then in case the time permits, I'll talk on anal canal. Rectum, I'll talk on three parts. First is anatomy, then comes physiology and pathology of rectum. Mind you, as far the MCQs are concerned, anatomy and physiology very rarely will be asked at your level. Why? Because the questions are very straightforward, the answers are very direct. So rarely you expect questions on anatomy and physiology of rectum. Three pathologies: solitary rectal ulcers, rectal prolapse, and CA rectum. Okay, again out of this, two pathologies you can easily omit: solitary rectal ulcers and rectal prolapse, because as I said previous, the answers are very straightforward. So what remains is CA rectum. Why CA rectum is important? And basically CA rectum is a very entertaining topic to the examiner, because there are lots of ifs and buts in CA rectum. Lots of new things are coming in CA rectum. Lots of new diagnostic modalities are coming in CA rectum. That's where CA rectum is the pet topic of an examiner, especially if he is setting an MCQs. Okay. In my lecture, I'll be just running through the topics on anatomy, physiology, solitary rectal ulcer, and rectal prolapse. I'll be stopping on CA rectum and taking some time discussing CA rectum. Okay. To begin with, what is rectum, or where does the rectum starts? The rectum starts at the left sacroiliac joint. There are different definitions where we define where the rectum starts. The rectum starts in the left sacroiliac joint. To some, the rectum starts at the S3 level. To some, it starts at the superior rectal fold. To some, it starts where the superior rectal artery divides into right and left branch. No need to mug it up. I put this slide especially in case you might get a true or false in these slides. Okay, that means the examiner asks you the rectum starts in 1, 2, 3, 4, which is false. So just go through this particular slide. There is nothing to be defined or there is nothing to be explained in this slide. These are very straightforward. Okay. I showed in the picture, rectum is basically which starts from the levator lower down and extends 15 centimeter above the anal verge. Three parts of rectum: upper rectum, middle rectum, lower rectum. Okay. Three folds: superior rectal fold, middle rectal fold, inferior rectal fold. This again is a very favorite question for the paper setter. They will give this picture and they'll tell you what is the extent in which you can examine a lesion by doing a per rectal examination, by doing a proctoscopy, by using a rigid sigmoidoscope, flexible sigmoidoscope, and colonoscope. So mind you, with proctoscope we can examine 8 centimeter up to lesions. That means lesion which is at least 8 centimeter from the anal verge we can detect by doing a proctoscopy. Little more than that, per rectal examination. That means per rectal examination at least till the sphincter. Okay. Third is rigid sigmoidoscope. Rigid sigmoidoscope almost like 18 centimeter. Move more ahead, 60 centimeter flexible sigmoidoscope. And better than that is a colonoscope which extends or gives a view of 160 centimeter of colon and the distal part of ileum. This picture again you need to memorize because a lot of questions are asked on this picture. Okay. Little bit of anatomy, as I said, the rectum starts at the puber rectalis and extends almost like 12 to 15 centimeter above it. There are three valves. What is the surgical anatomy of the valves? The superior valves defines the end of the rectum, okay, or the start of the rectum for that matter. Okay, that is one. If we mobilize the rectum or mobilize this particular rectal walls, we can get an extra 5 centimeter of the rectum. That is the important surgical anatomy. Again, important surgical anatomy, the superior rectal walls defines the peritoneal reflection. So superior walls, there will be an anterior and lateral peritoneal reflection. Middle rectal, there will be only anterior, and lower rectal walls, there is no peritoneal reflection. Okay. So that is the surgical anatomy of valves. Two important fascias as far as the rectum is concerned: anterior denonvillous fascia, which again has got two layers, and posterior valgus fascia. Just remember the names, nothing else. So as shown here, anteriorly there is a denonvillous fascia between the bladder and the rectum. There are two layers. During APR or doing AR, we need to dissect this particular plane. More important plane is posteriorly, where we have a presacral fascia and we have a mesorectal fascia. Connecting these two fascia is a denonvillous fascia. And when we are doing a AR or an APR, we need to cut this denonvillous fascia so that we are exactly into a right plane and not disturbing the sacral plexus. Okay, the sacral venous plexus, otherwise it will cause tremendous bleeding. Okay. So remember few fascias: presacral fascia, rectosacral fascia, denonvillous fascia. Rectosacral fascia is nothing but valgus fascia. Remember that. This picture you will find everywhere. What is important to know here is what is anorectal ring. Anorectal ring is nothing but is a combination of four things. Is a combination of pubis rectalis, deep external sphincter fibers, conjoint longitudinal muscles of the intestine, and highest part of the internal sphincter. Again, an MCQ might be asked. They will give you 3 or 4 options and you have to define which is false or which is true. Okay, so just keep this picture in mind. So that finishes off little bit about the surgical anatomy, or basically the surface anatomy of the rectum. What we now come to is the physiology. What is important in physiology is the angle. Okay, the angle created by the pubis rectalis with the rectum maintains the tone or maintains the continence of the rectum. If it is acute, patient will be continent. If it is more obtuse, patient will be incontinent. Remember this picture, nothing more or nothing significant to talk in this picture. Second important physiological point is the pressure. Remember, internal sphincter maintains the resting pressure, which is almost like 90 centimeter of water. Squeeze pressure is by external anal sphincter. Difference between the rectal pressure and the anal pressure maintains the continence. So that is the physiology. So two important part in physiology: one is the angle and second is the pressure. Okay, nothing much to talk. Just remember, you might get a direct MCQs on this. Okay. This is about the vascular anatomy. Again, I am not going to go in detail. Just remember, there is a superior, there are 3 arteries: superior rectal artery, which is a continuation of a sigmoidal vessels or a sigmoidal artery. Superior rectal artery, where it divides into right and left branch, is the start of the rectum. Okay, so superior rectal artery is a direct branch from IMA. Then comes the middle rectal artery. Significance of middle rectal artery: middle rectal artery are basically present on the lateral ligaments or the lateral pedicles. Okay, so in case you are dissecting lateral pedicles, it might bleed significantly. Second important surgical point is in females, this middle rectal artery may not be present. It is replaced by a uterine artery. Again, this could be an important MCQ question for you. And last is the inferior rectal artery, which comes from internal pudendal. So this is about the vascular anatomy. Same thing what I discussed here. There is one more anatomy, which is there is one more vessel, a median sacral artery, which is a posterior branch of distal aorta. Especially if you are dissecting posterior to the rectum, this is the vessel which commonly bleeds. Remember, again a question will be asked: which is the vessel which bleeds commonly posterior to the rectum? And median sacral artery is the commonest branch, not the sacral plexus. Sacral plexus bleed in case you are in a horribly wrong plane. Okay, but this is the vessel which commonly bleeds. Okay. Venous drainage, again same thing as the arterial supply. Just remember, the superior and the middle one drains into the para-aortic region or the IMA, and the inferior rectal drains into internal iliac vessels. Nothing much to talk about in this. This is the picture I will never forget, because I took almost 2 days to memorize this picture and understand the picture about the nervous supply of the pelvis. If you really want to see this picture, it is very confusing. You don't know which is sympathetic, which is parasympathetic. That's why it's simplified here. Remember, this is the aorta, right, left branch. Okay. So the pelvic nerves are divided into 2, sympathetic and parasympathetic. Understood? That is one. This is the sympathetic, which is coming from either side of the aorta. Just below the bifurcation of the aorta, the right and the left sympathetic joins, and what is called here is a superior hypogastric plexus. So till here again still it is sympathetic. Some superior hypogastric plexuses we get right and the left branch, nothing but right hypogastric nerve and the left hypogastric nerve. So till here again it is still sympathetic. So damage here is going to damage the sympathetic nervous system. Remember here up till here the parasympathetic is not come into picture. Parasympathetic starts somewhere here. And what is the origin of the parasympathetic is the S2, S3 and S4 fibers. These are called as pelvic nerves. Okay, S2, S3, S4 are called as pelvic nerves and these are preganglionic parasympathetic fibers. Remember this word, preganglionic parasympathetic fibers, because the ganglion lies here and it is proximal to the ganglion, that's why it is preganglionic parasympathetic plexus or fibers. Okay, this is the inferior hypogastric plexus. So just see here, the inferior hypogastric plexus is nothing but the mixture of sympathetic and parasympathetic. Okay, so the damage what is caused here, here and here will lead to different kind of disabilities. Okay, so remember this basic picture. Sympathetic hypogastric nerve again are sympathetic, inferior hypogastric plexus is nothing but a combination of sympathetic and parasympathetic. And from this the nerves arises and it supplies the bladder, the uterus and the rectum. The questions asked is what are the areas where this pelvic nerves gets damaged. So it can get damage here when you are dissecting the IMA or the inferior mesenteric artery, when you are ligating the base of inferior mesenteric artery. It can get damage at the superior hypogastric plexus when you are dissecting the posterior wall of the rectum. Then it can damage the hypogastric nerve. It can damage the lateral, if you are dissecting on the lateral wall, you can damage the parasympathetic here, you can damage the hypogastric. And in case you are very close to the organ, you are damaging both the parasympathetic as well as sympathetic. Understood this basic picture, don't get into detail, but at least understand the basic. The most important question asked is, what is this? So remember, this is nothing but the preganglionic parasympathetic nerve system. Okay? Parasympathetic supplies the muscles of the pelvis or the pelvic organ. Be it uterus, be it bladder, it supplies the muscles of the pelvic organ. Sympathetic supplies the vessels or the nerves of the vessels. Okay, so in case the parasympathetic is damaged, there will be overflow incontinence. That means bladder becomes flaccid because muscles are paralyzed, right? As I said, parasympathetic supplies the muscles. So when the parasympathetic are damaged, there will be a distension of the bladder and there will be an overflow incontinence. So that is one. Secondly, there will be something called as difficult or erectile impotence, because as I said, it supplies the muscles of the pelvic organ. So the muscles become flaccid, so the patient lands up with erectile impotence. Okay, so two important things, overflow incontinence and erectile impotence. Exactly ulta that happens in case the sympathetics are damaged. So in case you are damaging the hypogastric nerve, in case you are damaging the superior hypogastric plexus, exactly ulta happens. Bladder becomes spastic. एक इसमें क्या था, paralysis था, इसके लिए it was flaccid. In sympathetic it becomes spastic. Okay, so the muscles everywhere down the line get spastic, so bladder becomes spastic. Then the ejaculatory duct, the sphincter head, that gets closed, so that's why there is a retrograde ejaculation. So in both the cases, in case the pelvic system is damaged, patient lands up with infertility. But the cause of infertility, in case it's a parasympathetic part, is the erectile impotence which is happening, and in case it's a sympathetic, is basically a retrograde ejaculation. Understood? This is the only important thing in anatomy of a rectum where the MCQs can be based. So just clear this picture. Sympathetic, superior hypogastric plexus, hypo. So till here it is only sympathetic. Below that it is parasympathetic and sympathetic. Here again parasympathetic, sympathetic. Laterally it is only the parasympathetic. So these are pelvic nerves. This is also called as pelvic plexus. So inferior hypogastric plexus, remember the other name is pelvic plexus. Okay, these nerves are called as nervi regentis. So there are multiple nomenclatures which are given, but just don't get confused. These are nervi regentis, what we call. Okay, so that is only a parasympathetic supply. So as I said, three pathologies we are going to do. So we have finished up with the anatomy, we have finished up with the physiology. In anatomy, we have discussed the arterial supply, the venous supply, the nervous system. Okay, we have discussed the fascia, we have discussed the valves. Just simple basic things to understand. Now what comes in pathologies are three important things: rectal prolapse, solitary rectal ulcers and carcinoma rectum. I'll just run through the slides of rectal prolapse and solitary rectal ulcer, because as I said, most of the MCQs will be given to PGs, not at your level, because the answers are very, very straightforward. Okay. Two types of rectal prolapse: mucosal and full thickness, also called as procedentia. Causes of mucosal prolapse is basically excessive straining or weight loss. How do you differentiate this? Can be an important question for you. How do you differentiate that from the piles? They are pink and non-pedunculated. Piles are basically violet in color and then pedunculated. This is an important MCQ question for you in case an anatomy is asked in this particular respect. Okay. Procedentia, that is complete rectal prolapse. Here all the layers are prolapse, and basically the pathology here is a weakness of pelvic floor. Most of the patient, 50% of patients are incontinent. That's why in case you want to plan a repair, always do a manometry, because there will be pelvic incontinence. Two types of surgery: you can have a perineal approach, you can have an abdominal approach. Okay. Perineal approach, three common surgeries: Thiersch surgery, Delhomme surgery and Alzheimer's. That means we do a perineal rectosigmoidectomy. So remember these three surgeries in case you are doing a perineal approach. So Delhomme's procedure, Thiersch stitch and Alzheimer's rectosigmoidectomy. Okay. What is the advantage of perineal? In case patient is unfit, patient is old, we can have a perineal approach. The problem with perineal approach is the chances of recurrences are very high. That is the only problem with the perineal approach. Recurrences are very high. Okay. Exactly ulta happens with the abdominal procedure. In abdominal procedure, the recurrences are less, but the chances of constipation is very high. Okay. So perineal recurrence is high. Abdominal approach, the constipation is very high, and especially if you are using a mesh. Especially if you are doing a mesh rectopexy. Different types of rectopexy, depending upon where you fix the mesh, whether you fix it on the posterior part, the anterior part or the lateral part. Just remember the names. Wells procedure, out of these three procedures, just remember this Ripstein's. They commonly ask questions on Ripstein's. What is Ripstein's mesh plasty? Okay. In case there is a dictum, in case there is a constipation, do a resection plus suture rectopexy. In case there is no constipation, just do a mesh rectopexy. Remember this basic, that is important even as far as the clinical aspect is concerned. Okay. Solitary rectal ulcers, only couple of questions are important here. It's a misnomer. As I said, solitary is not actually solitary, it is 15%. Okay, 15% of the time, sorry, they are multiple. So remember that they will ask the incidence. How many times the solitary rectal ulcers are multiple? So answer is 15%. Remember this can be an important MCQ for you. Okay, common causes is straining, intersusception and everything. Now come to CA rectum. Why CA rectum is that important? Because any person who has a CA rectum, if not treated, the mortality is very high. Even if it is treated, the recurrence rates are very high. Even if it treated, the morbidity associated with the surgery is very high. Okay. But over the course of years, the things have changed. Why the things have changed? Because there are a lot of new things which has come up in the management of CA rectum. And what are those new things? First is TME, then has come the radiation, and third is the imaging. Imaging, when I am talking about imaging, I am talking about MRI. MRI and CA rectum is nothing like a husband and wife. You can't separate a CA rectum from an MRI. If you want to manage a CA rectum, you should know the MRI of that particular patient. Okay. Now again, how did I divide the topic of CA rectum? I will be talking on the TNM staging in CA rectum. I will be talking about the preoperative workup of CA rectum. In case everything is diagnosed, your stage, how are you going to decide which patient is going to require surgery, which patient is going to require chemotherapy, which patient is going to require radiation. So decision making in CA rectum, and last, different types of surgery or different types of surgical management of a growth in a rectum. That is management and that is a surgery. So this is the way I have divided the whole entire talk. Okay, TNM staging, preoperative workup, decision making in CA rectum and management or the surgical part. Before I go to the CA rectum or before I go to the TNM staging, I need you to understand certain important histological parts as far as TNM staging is concerned. When you cut the intestine, there are different layers you get. From inside out, it will be mucosa, next submucosa, third muscular propria. Okay, here the things gets divided. Okay, in case you have a serosa, that forms the fourth layer. In case you don't have a serosa, that becomes an adventitia. Can you give an example where there is an adventitia? Exactly, esophagus. So remember that. Okay, so in case it's an esophagus, there is no serosa, the adventitia forms the fourth layer. And wherever there is a serosa, which is a peritoneum, nothing but a peritoneum, it forms the fourth layer. So remember this basic thing about layers of intestine, because everything we are going to play depending upon the layers of intestine which are involved. Okay, so TNM staging depends upon which layer is invaded and which layer is not invaded. This is a simple picture to show the difference of epithelium in a malignancy of an esophagus and difference of invasion of an epithelium in a CA rectum. Why esophagus is invasive? We call invasive, why the esophagus CA are invasive is basically because again here the mucosa we divide into three parts. What are the three parts of mucosa? The epithelial layer, the lamina propria and muscularis mucosa. Okay. Why I need to discuss this? Because unless you understand this basic, you won't understand the concepts in oncology. Okay. Remember mucosa, three parts, epithelial layer, the lamina propria, okay, and muscularis mucosae. Why esophagus are invasive? Because even if an epithelium is involved, we call that as carcinoma in situ. And anything which is beyond that is an invasive carcinoma. That means even if the lamina propria is involved, even if the muscularis mucosa is involved, we call that as a invasive carcinoma. You understand the basic concept, invasive carcinoma and non-invasive carcinoma. In non-invasive, especially when you are talking about esophagus, even if one layer is involved of mucosa, that is the epithelial layer, okay, beyond that it is a invasive carcinoma. Non-invasive, that means only the epithelial layer is involved. Exactly ulta happens that in a CA rectum. In CA rectum, we need to have involvement of all the three layers of mucosa to call that it has gone beyond that. That means it has become invasive. That means only when it goes beyond muscularis mucosae, we call that as a invasive malignancy. That means if once it comes to submucosa, it becomes an invasive carcinoma in rectum. In esophagus, moment it goes below the epithelium, we call that as an invasive esophageal carcinoma. So that is the basic difference. Okay. Again, what is the other reason? Because there is no serosal coating, there is no covering there. The esophageal malignancy are more invasive as compared to a CA rectum. Remember this basic concept. Why CA esophagus is more dangerous as compared to CA rectum? Because CA rectum or rectum कोई छतरी रहता है serosa का. So serosa is acting like a barrier which is not there in esophagus. That's why esophagus is more invasive as compared to a CA rectum. This is the difference between the esophagus and rectum. Again in rectum, there are three different parts: upper rectum, middle rectum and lower rectum. It's not that T1, T2, T3, T4 सब में सेम ही रहने वाला है, because here as I said पेरिटोनियल कवरिंग जो रहता है अपर रेक्टम में एंटीरियरली है, लैटरली है, मिडल रेक्टम में सिर्फ एंटीरियरली है और नीचे तो है ही नहीं. So here your T1, T2, T3 and T4 are going to change. So when I'm talking about CA of an upper rectum, okay, T3 differs, T4 differs. When I'm talking about middle rectum, T3 differs, T4 differs. Same thing in lower rectum. Esophagus की तरह नहीं कि सब जगह पे कहाँ पे भी esophagus रहेगा तो we apply the same knowledge. Here the knowledge changes depending upon which part of the rectum is involved. समझा नहीं समझा, ऊपर से जा रहा है. Same picture depicting the upper rectum, the middle rectum and the lower rectum. Now what is T1? T1 is carcinoma. We'll come back again to CA rectum. Carcinoma C2 is basically involvement of mucosa. It doesn't have that potential to invade the lining of muscularis mucosae. That's why it has not gone beyond mucosae. That's why it is non-invasive, also called as carcinoma in situ. Anything which goes beyond this layer becomes an invasive carcinoma. So T1 is involvement of submucosa. Okay, understood? T2 is involvement of muscularis propria. And then here the entire thing changes. There is nothing, there is something called as T3, that is involvement of mesorectal fascia. Okay, so this is T1, that means involvement of submucosa. T2 is involvement of muscle layer. T3 is basically nothing but the involvement of mesorectal fascia. Okay, T4 here differs. T4 there are two parts, T4A and T4B. T4A is nothing but involvement of peritoneum or perforation of the peritoneum, and T4B is involvement of surrounding organs. Understood? So here there is no peritoneum. So directly after T3 is the surrounding organ. So there won't be a T4A. Directly after T3 it will come as T4B. समझे आपको concept? नहीं समझा? Because there is no serosa here, after T3 there is nothing called as T4A. It directly comes as T4B. The surrounding organs are involved, and here the surrounding organs could be bladder, it could be prostate. यहाँ पे क्या हो रहा है? यहाँ पे भी सिस्टम चेंज हो रहा है. अपर रेक्टम मिडल रेक्टम में अगर सीरोजा का बाजू आता है, दैट मीन एंटीरियर बाजू आता है, तो आपको सब मिलेगा, T1 मिलेगा, T2 मिलेगा, T3 मिलेगा, T4 मिलेगा. बट व्हेन इज पोस्टीरियरली विच इज डेफिशिएंट ऑफ सीरोजा, अगेन देयर विल बी T3, but there won't be T4A, directly it will be T4B. Understand this basic concept, okay? Then there is something again what is called as a satellite nodules. What are satellite nodules? These are nothing but a small tumor deposits on the rectal wall or the area which is near the tumor. Okay, there is one catch in that, I will tell you. Okay, so these are nothing but minor tumor deposits on the rectal wall or on the mesentery which is close to the tumor. Just remember these satellite nodules. Okay, again as I said, there is a catch in this. So after given this idea about the layers of the intestine, we come to the TNM staging. T staging, as I said, 1, 2, 3, 4. T1 is when the tumor is extended up to submucosa. T2 is up to muscularis propria. T3 is a pericolorectal tissue. Here in rectum it is a mesorectal fascia and the fat. T4 divided into two parts, A and B. A is basically involvement of peritoneum with perforation of the tumor. T4B is involvement of adjacent organ. End stage. So over the years this has not changed, this has remained same. The T staging has remained same. What has changed is in the end stage and the M stage. What has changed in the end stage? There are two types of N, N1 and N2. N1 is divided into three parts again, A, B and C. Remember this word, tumor deposit. What I showed in the previous figure, remember this thing, the tumor deposit. When there are tumor deposit, it becomes N1C. N1A is one node present, N1B is 2 or 3 nodes present in the mesorectal fat I am talking about, nodes in the mesorectal fat. N1C are the tumor deposit in the perirectal tissue or on the rectal wall. N2 are A and B, 4 to 6 nodes, more than 6 nodes. समझा इतना? What they have added in end stage new is this tumor deposits. Initially it was not there, and this is the new thing what they have added in 8 AJCC edition. Remember this, they can ask you what is new thing what has been added. So remember the tumor deposit are the new thing what they have added. Okay. M staging, again one more new thing they have added. Initially they had clubbed as with metastasis, without metastasis. But then again here what they have done, they have clubbed it into three parts, A, B and C. A is single organ involvement, that means अगर दोनों साइड का लंग भी फायर हो जाता है, tumors आता है, it becomes one organ. It is not that because they are on the two sides it becomes two. It becomes only one organ. But along with lung, if the liver is affected, it becomes two organ. So M1A is one organ, M1B is two organ. This is the new thing what they have come up with. M1C, that means peritoneal mets. So remember again important thing in new edition of 8 AJCC, the peritoneal mets has come into picture. Okay. So after understanding the basics of TNM staging, we will take couple of questions on the TNM staging. Okay. A 79-year-old male patient with a bleeding rectum, biopsy of an upper rectal growth shows an adenocarcinoma of a rectum. CT scan shows a lung and liver metastasis, but there are no peritoneal involvement. MRI pelvis suggestive of semi-annular mass invading the mesorectum anteriorly, at least 7 mm beyond the muscularis with 8 malignant lymph nodes. What is the clinical stage? This is very, very straightforward. First, understand there is a lung and liver mets. Understand this lung and liver mets. So it becomes what? M1B. Right? So this is way you come to the conclusion. So M1B है. तो अभी इसमें M1B के दो ऑप्शन है, B और D. तो आपका आंसर या तो B रहेगा या फिर D रहेगा. इसमें से आपको आंसर नहीं मिल रहा है. एक क्लू आपको मिल गया मेटास्टेसिस के बारे में. देन कम टू द सेकंड क्लू. सेकंड क्लू इज ऑफ नोड्स. नोड्स क्या बता रहा है इधर? 8 नोड्स. 8 नोड्स में कौन सा आएगा? N2. A आएगा कि B आएगा? 8 नोड्स है, सो B आएगा. ओके, तो ये दो मैच हो गए. अल्टीमेटली व्हाट रिमेन्स इज T3. सो आंसर इज T3C, N2B and M1B. Understood? So this is way you come to a conclusion or you finalize your answer. Okay. So answer is T3C, N2B and M1B. Okay. Similar situation again here. Same patient, but here the MRI findings are little bit different. Here the MRI pelvis shows a semi-annular mass which is invading the mesorectum anteriorly at least 7 mm beyond the muscularis with 3 malignant nodes and the tumor deposits over the rectal wall. What is the clinical stage? इसमें थोड़ा सा MRI फाइंडिंग चेंज हुआ है. मतलब यहां तक सब ठीक था, यहां सब ठीक है. आगे वाला जो फाइंडिंग है 3 malignant nodes and tumor deposits of the rectal wall has changed. So what will be your diagnosis or what will be your answer? Option A, B, C, D. What? So again here lung and liver metastasis है तो M1B आ गया डायरेक्टली. ये तो क्लियर हो गया. सो ऑप्शन शुड बी आइदर B और D. व्हाट नेक्स्ट? ट्यूमर डिपॉजिट्स है तो क्या आएगा? C आएगा. ओके, सो व्हाट शुड बी आंसर? गधे लोग नहीं, आंसर ये नहीं है. मैं आपको पहले क्या बोल रहा था कि कुछ तो कैच है करके. इसमें क्या कैच है? कैच क्या है? नोड्स भी है और ट्यूमर डिपॉजिट्स भी है. ट्यूमर डिपॉजिट्स के बारे में क्या इंडिकेशंस था? ट्यूमर डिपॉजिट्स के बारे में क्या था? देयर शुड बी नो लिम्फ नोड. मैं पर्पसली वो हाइड किया था. देयर शुड बी नो लिम्फ नोड, देन ओनली वी कॉल दैट एज अ ट्यूमर डिपॉजिट. समझ गए? देन ओनली इट बिकम्स 1C. मोमेंट द लिम्फ नोड कम्स इनटू पिक्चर इट बिकम्स आइदर 1AB और N2AB. Okay, so this is a catch or this is a googly question. Remember, this is a very, very pet question of an examiner. This is how they put the googly to you. That means they have shown you कि यहाँ पे tumor deposits भी है तो directly you will answer that as N1C. Here is not an N1C. Okay, because there are 3 malignant nodes, it becomes N1B. Understood or no? So this is how the examiners fools you with a catch. One more question we'll take on TNM staging. Regarding the T staging of rectal cancer, which is the wrong statement? Mercury trial established that MRI is the best modality for T staging. T4B indicates that the lesion has invaded the peritoneal reflection. T3C indicates the tumor growth up to 15 mm beyond muscularis propria. And MRI estimation of depth of invasion is accurate to less than 0.5 mm of final pathological specimen. Again a very straightforward question. Very straightforward. इसमें कुछ कैच नहीं है. For a change. Mercury trial. Remember this trial. Mercury trial is basically a very important trial as far as CA rectum is concerned. It showed that MRI is the best investigation as far as T staging is concerned and especially T3, T4 as compared to an endorectal ultrasound. Remember this very important trial, Mercury trial. So this is the right answer. T3C indicates tumor growth up to 15 mm beyond muscularis propria. Till now I was telling you about T1, T2, T3 and T4. But remember again here T3 has got 4 components, T3A, B, C and D. That depends upon the level of invasion of tumor. Less than 1 mm is T3A, 1 to 5 mm is T3B, 5 to 15 mm is C and beyond 15 mm is D. Okay, so again this option is also right. T3C indicates 15 mm beyond muscular papilla. This again is right. What is problematic here is T4B indicates a lesion has invaded the peritoneum. Is that so? T4A indicates peritoneal involvement. Okay, so answer here is T4B indicates a lesion is the right answer. Okay. Now, so we have finished up with the TNM part. Now we come to the questions, or we have come to the topic of investigation. Okay. As far as investigations are concerned, there are a couple of investigations which are very, very important as far as the rectum is concerned. Most important tumor marker is what? CEA. Okay, so that you should know. When it comes to CA rectum, you should know about CEA. Then next investigation is endorectal ultrasound. Third investigation is MRI rectum. Fourth investigation is CT, abdomen and pelvis. And fifth is PET scan. Out of these 5 investigations, the first 3 what I mentioned are clinically more important for you, because there are very few indications of doing a PET scan. We will come to that. There are very few and there are very standard indications of doing a CT scan. The problem happens with endorectal ultrasound and MRI. When to do what? Okay. So as I said, these are the investigations or the series of investigation we do when it comes to a CA rectum. We will take a couple of questions as far as the CA is concerned. CEA precedes both clinical and radiological recurrences. Useful tool for CRC screening. CE level normal in more than 50% of CRC patients, and useful tool for CRC surveillance. Any guesses on this? How many for A? How many for A? नहीं, साला हाथ ऊपर किया बाद में नीचे लिया. What do you mean by this? CEA precedes both clinical and radiological recurrence. What do you mean by this? That means मैं CA rectum का सर्जरी कर लिया हूँ, ठीक है. Now I am basically in a post-op follow-up. तो समझो अगर मेरा whatever investigations are done have come back to normal, but the CA is raised. So CA is an early indicator कि आपको 6 महीने के बाद डेवलप हो सकता है, रिकरेंस डेवलप हो सकता है. So that's why it is basically like something like advanced booking. So CA is the best indicator to say that in future I am going to develop the recurrence or no. That's why it precedes both clinical and radiological. I may not have symptom, that means clinical. I may not have any investigation to suggest that the recurrence, but a rising CA level may suggest that I might develop a recurrence. That's why this statement is true. Okay. CA level normal in more than 50% of CRC patients. True or false? Is true, because CA is raised only around 20 to 40% of patients. In almost 60% of patients, it may be normal. Okay. Again, a rise in CA value need not be always a CA rectum. It could be also present in other non-GI malignancies or other GI malignancies, inflammatory bowel disease, pancreatitis. So again, this is what? A true statement. CA level normal in CRC patient. This is a right statement. Useful tool for CRC surveillance. Surveillance means basically post-op follow-up. So definitely it indicates whether the patient is going to develop recurrence or no. Okay. Or metastasis or no. The problem here is useful tool for CRC screening. Screening मतलब screening कभी करते हैं जब भी वो 100% इंडिकेट करता है कि ये कैंसर ही है. बट अभी आपने बताया कि जो ये सेक्शन सी है उसमें it can be normal in more than 50% of patients. How can you use it for screening? So this is the wrong answer. Understood or no? So it's not used for screening, but it can be used for surveillance. There's a difference here. Remember that. स्क्रीनिंग कभी यूज करते हैं कि सिर्फ मैलिग्नेंसी में अगर इंक्रीज होता है तो भी हम लोग स्क्रीनिंग करेंगे, लेकिन अगर नॉर्मल पेशेंट में भी वो बढ़ता दिखता है, दैट मींस आई एम लेबलिंग नॉर्मल पर्सन एज सीए रेक्टम. ओके, सो आंसर हियर इज यूजफुल टूल फॉर सीआरसी स्क्रीनिंग इज अ फॉल्स स्टेटमेंट. So something about CA is nothing but a glycoprotein, is basically produced by goblet cells, and mucous cells is nothing but an addition molecule. Okay, so it is produced by goblet cells and a mucosa of an intestine, can be raised in a non-GI malignancy. More importantly, the half life of CA is 14 to 15 days. मतलब अगर आज मैं CA rectum निकलता हूँ, ट्यूमर निकलता हूँ, तो tomorrow the things are not going to come back to normal. It's only after 15 days the things are going to come back to normal. That's why the half life, that's what it says, the half life is 14 to 15 days. So it comes back to normal only 2 to 3 weeks after surgery. Again, as I said, it's sensitive than clinical imaging guidance in telling the recurrence or distant and increase in 17 to 47%. That means more than 50% of normal patients will also have a raised CEA. So this is what you should know about CEA. Next investigation. Sensitive than MRI in detecting T-stage, operator dependent, difficult in obstructing lesion and mesorectal nodes are better seen than MRI. How many for A? You for A. How many for B? How many for C? And how many for D? Yes, here you are absolutely right. That means it's very difficult to judge the nodes present or not present in endorectal ultrasound. There are definitely some kind of indications where endorectal ultrasound is going to be beneficial than MRI. Endorectal ultrasound is useful for detecting a minor lesion which is there in T1 and T2. But when it comes to T3 and T4, MRI supersedes that. Okay. Other advantage of endorectal ultrasound, this is I am talking in relation to MRI. But if you really compare MRI and endorectal ultrasound, T1, T2 lesions are better detected by endorectal ultrasound than MRI. T3, T4 lesions are better detected by MRI. Okay. Nodes. Nodes का भी इसमें कैसा है कि if the lesions are more than 3 mm, if the nodes are more than 3 mm, endorectal ultrasound can pick up. But if they are less than that, it's very difficult to pick up on endorectal ultrasound. Can you give me an advantage of an endorectal ultrasound? Depth of invasion तो बता दिया. Anything else specific? Biopsy. So again an advantage of an endorectal ultrasound. In case you want to do a biopsy of a lymph node or a tumor, this will help you. Otherwise, so remember here endorectal ultrasound beneficial is only in T1 to T2 stage. Apart from that, the best thing to have is an MRI. Okay. So answer here is mesorectal nodes better seen than MRI is a false or is a bad statement. See again here it has come as mercury trials. Remember this mercury trial, as and when you read a CA rectum, it always come across this mercury trial. So mercury trial says that MRI is better than endorectal ultrasound. Remember this. They can give you this picture of an endorectal ultrasound and will point an arrow in one particular layer, and they will help you or they will ask you what is this layer. So this picture, so they can put this as an MCQ also. So you should know which particular arrow depicts which layer. So basic thing is muscle will appear black. Okay. So inner black layer is a muscularis mucosae. The outer black layer is nothing but muscularis propria. So remember this basic thing. And anything which is outside that is the perirectal fat or the mesorectal fat. Okay, so lymph nodes will be here, here and here. Understood? So ये basic concept जो है endorectal ultrasound का, they might put in a picture and tell you to identify which is what layer, and especially they will ask you to identify the muscularis or this layer, black layer. Usually people tend to put this white layer as a muscularis propria, but it's not that, it's exactly ulta. This black layer is muscularis propria, the inside black layer is muscularis mucosa, and this is the epithelium. Okay. Same thing what I told you here, nothing new in that, that is endorectal ultrasound better in T1, T2, MRI better in T3, T4. Okay. Now this is a picture, a normal picture of a MRI. Okay, this is the mucosa. Okay, these are the layer of rectum, black thing again here, the muscularis propria. The white thing here is the mesorectal fat, and this black line here, they will show you, again they will show you this picture and they will tell you to identify what is this picture. This black line is nothing but the mesorectal fascia. So mesorectal fat, mesorectal fascia. Okay, and inside the mesorectal fat, whatever lines you see, if there is a linear thing, it is nothing but the vessels, and the round things, they are nothing but the lymph nodes. Okay, just understand this basic concept. Now, there are definitely some advantage of MRI over endorectal ultrasound. First, it will show you the extent of the tumor, that means whether it is arising from upper rectum, middle rectum and lower rectum. Okay, that is the first thing. In endorectal ultrasound, if suppose if it's an obstructed lesion, you won't be able to pass the probe. So you won't judge or you won't know the upper limit of CA rectum. Okay, but in MRI you could easily identify that means arising from which part and what is the extent. Okay, so here it's the upper part. If you join this coccyx and this pubic tubercle, anything which is above this line will be an upper rectum. Okay, so that is the first advantage of MRI. Second advantage of MRI, it will show you this, definitely there is a growth here, okay, and it will show you something in the mesorectal fat also. Okay, here they are showing the growth, muscularis propria, and there is a growth here. Okay, it has not invaded into the mesorectal fat, but just see here, there is a growth here which has invaded the muscularis propria, as well as there are some kind of round structures here seen, some kind of linear structures what we see here. So this is nothing but the lymphovascular invasion, and this is nothing but the lymph node involvement. So as I said, MRI will show you the accurate picture of T3, T4. MRI will show you the involvement of mesorectal nodes, and MRI will show you lymphovascular invasion. Anything else apart from this information? It will also show you whether the peritoneum has involved or not, especially when it comes to upper rectum. Okay, this is the bladder here, this is the growth, and this is the peritoneum. So it will show whether the peritoneum is involved or no. So what is the importance of MRI? As I said, it will give an accurate T staging to the tumor. It will show the involvement of vessels. It will show the involvement of nodes. Again, there is a catch here. Not all nodes are positive for malignancy. There are certain criteria what they are defined on MRI which will depict that this is malignancy. That again is less, if the node is less than 5 millimeter, more than 5 millimeter, 5 to 10 millimeter, and more than 1 centimeter. If the tumor or if that particular lymph node is round, suggests more of malignancy. If the tumor or if the lymph node is heterogeneous, suggests more of malignancy. Okay, so remember this basic thing. All lymph nodes what you see in MRI are not malignant. Malignant lymph nodes has got typical features on MRI. So as I said, an heterogeneous architecture, a round lymph node mostly and a bigger lymph node more than 1 centimeter suggests malignancy in MRI. So that is an advantage of MRI. So normally how do you work up for rectal cancer? That means what are the investigations you do for rectal cancer? As expected, you always do a biopsy just to confirm whether this is malignancy or no. MMR, MSI testing, what is this? What is MMR, MSI? Micrometastasis, mismatch repair genes, or microsatellite instability. Why this? What does this diagnose? HNPCC or Lynch syndrome. Remember this. So we need to diagnose what we are dealing as a CA rectum. Does it come under picture of Lynch syndrome or is just an other lesion or a sporadic lesion? Okay. So that's why always in any case of colonic malignancy or rectal malignancy, you should do MMR or MSI testing. You do a colonoscopy to see whether there are any other synchronous lesion. Again, whether it falls under Lynch, whether it falls under FAP, or it's again a sporadic isolated tumor. Okay, so that's why in case it's not obstructed, you do a colonoscopy. In case it is obstructed, after surgery, maybe after 6 months, you do a colonoscopy. Understood or no? So these are the basic investigations what you are going to do. CT scan of chest and abdomen, we do especially to know the liver metastasis. Okay, and ascites. That means whether it's a metastatic tumor or no. CBC, chemistry, CA, pelvic MRI, as I said, endorectal ultrasound. Important catch here, we don't do PET scan or PET CT as a workup for rectal cancer. Important catch here, remember this. Exactly ulta happens in case is a CA anal canal. In CA anal canal, as a pre-operative workup, we do a PET scan. Here, we don't do a PET scan as a routine workup. As I said, there are specific indications where we do a PET scan in a CA rectum. Okay. Two important investigation, that means post-operatively there is a rising CA level where we suspect a metastasis or a recurrence. That is one indication. Second indication where we do a CA level, a PET scan as far as the CA rectum is concerned. Any guesses? If there is a CA or if there is a liver mets, we do PET scan. There is a question put forward there. Yes, because in case you want to operate on a liver metastasis, first you have to confirm whether that is the only site where there is a metastasis or whether it has spread to whole body. अगर सब जगह पे फैला है तो फिर liver का ट्यूमर निकाल के मतलब ही नहीं है. So that is the other area where we do a PET scan in case there is a liver mets and you plan to remove the liver mets. Okay, so two indications where we do a PET scan to know the in case of rising Ca level, in case we want to know the distant metastasis or recurrence, and in case we are planning for a resection in a liver metastasis. Okay, so we have finished up with the investigation. So we have talked about the rectal anatomy, we have talked about rectal physiology, we have talked about the basic pathology of solitary rectal ulcers, we have talked about rectal prolapse. We came to CA rectum. In CA rectum, we talked about TNM staging, we talked about the investigation. Now, the third important part in discussion is how are we going to decide which patient is going to require chemotherapy, which patient is going to require surgery, radiotherapy, depending upon the staging, and what are the different modalities of treatment available as far as the CA rectum is concerned. So, initially we used to do only resection, that means we used to do only TME or a local excision, but they found that the results are not good in all the patients. So, that is why they added chemotherapy. So, first they begin with total mesorectal excision or a local excision, AR, APR or a local excision. इसके बाद to improve the chances of survival or the overall survival and to prevent the local recurrences, they added chemotherapy in this. इससे भी उनका satisfied, these people didn't get satisfied. They said in case we give a long course chemoradiotherapy, the chances of local recurrences or metastasis are less and the overall survival is improved. So, there came the picture of long course chemoradiotherapy. Option to long course chemotherapy because it was a long, as the name suggests, a long course, so it used to take a lot of time. Then they came up with the idea of short course radiotherapy with TME. Next concept was short course radiotherapy with delay and then surgery. Then came a long course chemoradiotherapy and just wait and watch. Then came totally neoadjuvant chemoradiotherapy. That means we are not going to operate on this CA rectum, we are just going to give a neoadjuvant chemoradiotherapy, what we give for a CA breast, early CA breast, and just observe. Okay? So, these are the different modalities of treatment what were available as far as the CA rectums are concerned. So, we will take some questions now on decision making here. A 49-year-old man presents with a biopsy which is proven to be carcinoma and which is 15 centimeter above the anal verge, which will not form the part of his management. Colonoscopy, MRI pelvis, neoadjuvant radiotherapy and proctoscopy. How many for A? How many for A? How many for B? How many for C? How many for C? How many for D? Proctoscopy. Why not proctoscopy? You should always do a proctoscopy. The answer here is neoadjuvant radiotherapy. Remember one thing, as far as the management is concerned, the mid rectum and the lower rectum has got a similar management, and most of the time the management is chemotherapy followed by surgery. When we are talking about upper rectum, we are talking like we are managing a CA colon. So, management of CA colon and management of upper third of rectum is almost the same. Do we give chemotherapy for a CA colon first? No, the same thing applies here. That means we are not giving a neoadjuvant radiotherapy. So, the answer here is neoadjuvant radiotherapy. We obviously do a colonoscopy, we obviously do a MRI pelvis and proctoscopy. These are investigation. What we don't give in an upper third rectum, see, remember this is 15 centimeter above the anal verge, that means it is an upper third rectum. You missed out on that, 15 centimeter above the anal verge. Any tumor which is in the upper third, we consider that as management same as that of a colon, remember that. So, in colon we don't give chemotherapy, neoadjuvant chemotherapy, the same applies here. In upper third of rectum we don't give neoadjuvant radiotherapy. Okay. So, the rectum can generally be divided into thirds, lower, middle and upper. The upper rectum extends about 12 centimeter from the anal verge. Tumors of upper rectum at the level of sacral promontory are labeled rectosigmoid because they can behave similarly to the colon cancer. Their surgical management is analogous to the management of colon cancer. Neoadjuvant radiotherapy is not a part of colon cancer management. So that's why that particular answer. Okay. Then comes long course chemoradiotherapy. Remember this again, a very important concept. So as I said, initially people started doing APR, AR, but they found the results were bad. Then they started looking into chemotherapy. So they started giving post-operative chemotherapy. Again, the results were not good. Then they thought we'll give pre-operative radiotherapy. So they came up with this idea of long course chemoradiotherapy. Okay. What do you mean by long course chemotherapy? That means there is a sandwich of radiotherapy and surgery in multiple attempts of chemotherapy. That means पहला chemotherapy, तीसरा chemotherapy, पांचवा chemotherapy, उसके बीच में ये radiotherapy आ जाता है, ये surgery आ जाता है. So long course, as the name suggests, long course chemoradiotherapy. That means we give initially 5-fluorouracil capecitabine, okay, as an infusion. Then we give radiotherapy for 6 weeks. Dose of 1.8 to 2 guy 5 days a week. Again, after finishing radiotherapy, you come up with chemotherapy. After chemotherapy and after 6 weeks of this radiotherapy, you plan to operate on this patient. And then after surgery, no matter whatever is the histopathology, you still give chemotherapy. This is what we define as long course chemoradiotherapy. Okay? But they found long course chemotherapy, as the name suggests, causes lot of time. Okay, so patient may not follow up. So that's why they invented what is called as a short course radiotherapy. इसमें चेंजेस क्या किया कि पहले कीमोथेरेपी देते थे, पहले यहाँ पे कीमोथेरेपी नहीं, पहले डायरेक्टली ये लोग ने क्या किया, नो न्यू एडजेंट कीमोथेरेपी वाज गिवन, इट वाज डायरेक्टली रेडियोथेरेपी एंड देन इमीडिएटली सर्जरी विद इन 7 days. Or after surgery they used to give chemotherapy. Understood or no? The basic difference here is pre-operatively they never started with chemotherapy. They first gave radiotherapy, then they came up with surgery again within 7 days. Initially पहले कैसा करता था हम लोग, रेडियोथेरेपी के बाद 6 हफ्ता रुकता था, उसके बाद हम लोग सर्जरी देता था. पर इसमें उन्होंने क्या किया, रेडियोथेरेपी दिया एंड सर्जरी विदिन 7 days. एंड आफ्टर 7 days immediately once the patient is stable, they opted the patient for chemotherapy. So as the name suggests, short course radiotherapy. Okay, but as it all says, advantage was it was fast, cost effective and we can give an early post of chemotherapy. Problem क्या होता था कि अगर bulky tumor रहता है, so this will not work. You need the bulky tumor to reduce in size. Immediately अगर आप ऑपरेट करोगे तो साइज कम होने वाला नहीं है, तो वो bulky tumors के लिए उसका कुछ फायदा ही नहीं है. So in case you want that radiotherapy to actually decrease the size of the tumor, you need to wait. So that was the disadvantage, and that's why it came to that particular thing as short course radiotherapy plus delay. That means you wait for the tumor to shrink. Okay, so by waiting, what you are doing is you are allowing the tumor to shrink so that you can eventually plan for AR or AP or whatever. Okay, plus the chemotherapy acts or the radiotherapy can be easily given. Remember this trial again here. Like there was a mercury trial for endorectal ultrasound and MRI, here there is something called as a Stockholm trial, which says that the results of short course radiotherapy with delay is almost equal to long course chemoradiotherapy. So these are the two important trials, remember, as far as the CA rectums are concerned, Stockholm trial and mercury trial. Total, then there are some people who started believing only I will give only neoadjuvant radiotherapy, I will not operate. But there are very selective group of such surgeons which give only neoadjuvant chemoradiotherapy. That is not followed everywhere. Then there is some again a new policy which has come up is wait and watch policy. That means you give long course chemoradiotherapy and just wait and watch. If the tumor shows a complete response, just observe, don't do anything. But in case there is no response, in case there is an incomplete response, then you plan the patient for surgery. So this is typically about wait and watch policy. Okay, so these are the basic concepts what are available, or these are the basic modalities what is available with this in case the patient comes with CA rectum. Understood or no? Okay. What is the importance of lateral pelvic node dissection? When I am talking about lateral pelvic node dissection, that means I am talking about internal iliac nodes, external iliac nodes, para-aortic nodes. Do we really need to do that? No, because the chances of malignancy in this is only 20 to 30%, in case the tumor is T3 and T4. That's why in all patients you need not do a lateral pelvic lymph node dissection. In case you still want to do a node dissection, only do it on one side, not on both the sides, because the survival doesn't change, the outcome doesn't change. Okay, so this again can be an important question for you. They will give an answer that lateral pelvic node dissection is planned, whether it improves the survival or no. No, the survival doesn't improve. And in case you want to plan a node dissection, you do it only on one side. Okay. Then some surgeons, apart from TME, they do an extended resection or do a prophylactic oophorectomy. Extended resection means that means they remove the affected organs, be it bladder, be it uterus. Okay. So after giving an idea of different options available for treating a CA rectum, we will again take some MCQs here. Time 2:45. A 70-year-old man comes with bleeding rectum. On proctoscopy, the lesion is 6 cm from anal verge. On colonoscopy, it is 2 cm lesion occupying less than 1/3 of circumference. MRI shows lesion localized to rectal wall with no lymph nodes. Biopsy shows well differentiated adenocarcinoma. What is the next line of management? Transanal excision, neoadjuvant chemoradiotherapy, endo ultrasound and LAR. How many for A? इसमें क्या क्या दिखा है आपने को, उसने कितना दूर है एनल वर्ज से वो बताया 6 सेंटीमीटर. दैट मीन्स वी कैन स्टिल डू एन AR. सो APR इज आउट ऑफ क्वेश्चन हियर. ओके, सो व्हाट रिमेन्स इज AR. वो एक पॉसिबिलिटी है. बाद में वो लोग ने क्या किया, कोलोनोस्कोपी किया, उसमें 2 सेंटीमीटर लीजन बताया विच इज इन्वॉल्विंग ओनली लेस देन 1/3 ऑफ सर्कमफरेंस एंड इट इज इन्वॉल्विंग ओनली द रेक्टल वॉल, नो लिम्फ नोड. दैट मीन्स रिमेंबर इट्स अ रिसेक्टेबल ट्यूमर. ओके, तो रिसेक्टेबल ट्यूमर में क्या क्या ऑप्शंस आपके पास अवेलेबल है? क्या डिसाइड करता है कि आप ट्रांसएनल एक्सट्रूशन करोगे या फिर AR करोगे? उसके पहले आप कुछ इन्वेस्टिगेशंस करोगे. आपको मैं बताया था ये इंपॉर्टेंट पॉइंट व्हेन आई वाज टॉकिंग अबाउट सम इन्वेस्टिगेशन. T1 और T2 में कुछ फर्क है मैनेजमेंट में. T1 अगर है तो टू सम एक्सटेंट वी कैन प्लान. If the tumor growth or if the tumor has a favorable histology, we can do a transanal excision. T2 है तो उसको transanal excision नहीं कर सकते, उसको AR ही लगेगा और APR ही लगेगा. ठीक है, अभी उसने क्या दिया है कैच की, उसने सिर्फ बताया कि rectal wall is involved, but what rectal wall, what layer of rectal wall उसने बताया इसमें नहीं है. तो ये कैसा पता चलेगा आपको? Exactly. So here the answer is endorectal ultrasound. So the next step here is to do an endorectal ultrasound and to know whether the which layer has involved. T1 is involved and T2 is involved. If T1 is involved, plan for transanal excision. If T2 is involved, plan for AR or plan for AR, not APR here because it's 6 centimeter from the anal verge. Okay, so answer is EUS. 80-year-old man with a history of bleeding PR. On digital examination, there is a circumferential growth 8 centimeter from the anal verge. Biopsy is suggestive of moderately differentiated adenocarcinoma. CA 65. MRI shows disease which is 3 mm away from the mesorectal fascia with suspicious nodes which are having round irregular border with heterogeneous enhancement. That means it is all suggestive of a malignant nodes. Nodes or distant metastasis CT scan. Next line of management will be, that means what? एक तो ये T3 ट्यूमर है बराबर, बिकॉज इट इज इन्वॉल्विंग द मेसोरेक्टल फेशिया. दैट मीन्स इट इज इन द मेसोरेक्टल फ्लैट 3 mm अवे फ्रॉम द मेसोरेक्टल फेशिया. T3 है, N1 है या फिर 2 है, बिकॉज वॉट एवर नोट्स दे आर मेंशन्ड हियर इज सस्पिशियस ऑफ मैलिग्नेंसी. सो T3 है, N1 हो सकता है, N2 हो सकता है, बट मेटास्टेसिस नहीं है. तो क्या करोगे आप इसमें? विल यू डू डायरेक्टली लो एंटीरियर रिसेक्शन? नहीं करोगे. एब्डोमिनल पेरिनेल रिसेक्शन नहीं करोगे. डाइवर्टिंग लूप कोलोस्टोमी करोगे. पेशेंट नॉट इन ऑब्स्ट्रक्शन. सो आंसर हियर इज neoadjuvant chemotherapy. Remember, T1 ट्यूमर है, 2 ऑप्शंस अवेलेबल फॉर यू, ट्रांसएनल एक्सिशन और डायरेक्टली TME. T2 है तो TME. T3 है तो पहला neoadjuvant रेडियोथेरेपी, उसके बाद फिर सर्जरी. और T4 है तो अगेन सेम थिंग, पहला कीमोरेडियोथेरेपी उसके बाद फिर सर्जरी. रिमेंबर दिस बेसिक फंडा ऑफ मैनेजिंग अ CA रेक्टम. So answer here is neoadjuvant chemoradiotherapy. 70-year-old man diagnosed with CA rectum 6 cm from the anal verge. preoperatively as T1 with all other investigation. Preoperatively it was diagnosed as T1 with all other investigations showing no evidence of metastasis. Underwent transrenal excision, final histopathology report came as T2. What is the next line of management? Simple बताऊं तो उसने T1 सोच के वो ट्यूमर निकाला, ट्रांसरेनल एक्सिशन किया है, हिस्टोपैथ के लिए भेजा, T1 का T2 हो गया. तो आपका मैनेजमेंट कैसे बदलने वाला है? आर यू गोइंग टू जस्ट ऑब्जर्व दिस पेशेंट? आर यू गोइंग टू गिव अ लोकल रेडियोथेरेपी फॉर दिस पेशेंट? आर यू गोइंग टू गिव पोस्ट ऑप कीमो रेडियोथेरेपी फॉर योर पेशेंट? और आर यू गोइंग टू डू अ लो एंटीरियर सेक्शन? हाउ मेनी आर फॉर सी? अरे डायरेक्टली बोला है मैं, सी मतलब वही आंसर रहेगा ना. यू आर फॉर सी. वाई सी? यू आर राइट. वाई सी? दैट मीन्स हियर द ट्यूमर इज स्टिल ऑपरेबल. छोटा लीजन है, सिर्फ T1 का अपग्रेड हो गया, T2 हो गया है, बाकी कुछ नहीं है उसको. बाकी एवरीथिंग और ऑल इन्वेस्टिगेशंस आर नॉर्मल. प्री ऑपरेटिवली other investigations showing no evidence of metastasis. So that metastasis could be in the lymph node, could be in any other organ. तो ट्यूमर छोटा है, मेटास्टेसिस नहीं है, तो आप एक्सरसाइज तो करोगे उसको. ट्रांसरेनल ऑलरेडी कर चुके हैं, तो अभी ट्रांसरेनल के ऊपर क्या आएगा? ये आएगा ना लो एंटीरियर रिसेक्शन, बिकॉज उसने 6 सेंटीमीटर बताया है. अगर समझो इसका 6 सेंटीमीटर की जगह पे 3 सेंटीमीटर रहता है, सो विल डू एन APR. सिंपल. ओके. एवरी स्टेप हियर और एवरी स्टेटमेंट हियर इज इंपॉर्टेंट. A 40-year-old man with history of bleeding PR, on digital examination there is a circumferential growth which is 8 cm from the anal verge. Biopsy is suggestive of moderately differentiated adenocarcinoma. CA is 65. No evidence of distant metastasis on CT scan. Patient underwent neoadjuvant chemoradiotherapy. Post chemoradiotherapy MRI shows partial response. What is the next line of management? Sorry. What is the next line of management? Will you give a chemotherapy? That means they have said कि ये पेशेंट जो ऑपरेबल था, ठीक है, उसको न्यूएडजुवेंट कीमोथेरेपी दिया, उसके बाद इट हैज शोन अ पार्शियल रेस्पॉन्स. विल यू अगेन गिव अ सेकंड ट्राई ऑफ कीमोरेडियोथेरेपी? सेकंड ट्राई ऐसा कुछ रहता है कीमोथेरेपी का? नहीं. तो दिस ऑप्शन इज आउट. विल यू डू एन इमीडिएट LAR? पेशेंट को अभी जस्ट रेडियोथेरेपी मिला है, तो आप इमीडिएटली LAR करोगे इसका? नहीं. सो यू विल वेट फॉर 6 वीक्स. आप 6 वीक्स रुकते हो, लेकिन पेशेंट को रेडियोथेरेपी मिला, ये बराबर है. यू आर प्लानिंग LAR आफ्टर 6 वीक्स, बट पेशेंट को रेडियोथेरेपी मिला है, तो विल यू लाइक टू टेक अ चांस ऑफ जस्ट डूइंग एन एनास्टोमोसिस विदाउट डूइंग अ डाइवर्टिंग स्टोमा? नो. सो दिस पेशेंट is going to require an LAR with covering stoma 6 weeks after radiotherapy. So this is the option. Understood or not? Am I going too fast? Is it getting bored? You tell me. We'll stop on this part. Should we take a break? No. So answer is LAR with covering stoma 6 weeks after radiotherapy. Next question. 80-year-old man with history of bleeding PR. On digital examination, there is a circumferential growth 8 cm from the anal verge. Biopsy suggestive of moderately differentiated adenocarcinoma, CA 65. MRI shows T2 disease. No distant metastasis. Patient underwent neoadjuvant chemotherapy and shows partial response. What is the next line of management? What is the next line of management? History of bleeding PR on digital examination growth 8 cm from the anal verge. Biopsy suggestive model. MRI shows T2 disease. No distant metastasis. Simple है, 8 cm है growth from the anal verge. Will you plan for APR or AR in this patient? AR. So answer is LAR. Okay. अभी यहाँ पे सेम क्वेश्चन है, सिर्फ उन्होंने क्या गलती किया है, अपने को स्पिंक्टर का एक हिंट दिया है. इज अ लैक्स स्पिंक्टर. ओके, तो जब भी लैक्स स्पिंक्टर आता है, वी विल नॉट प्लान फॉर स्पिंक्टर प्रिजर्विंग सर्जरी. दैट मीन्स APR AR आउट हो जाता है, इंटरस्पिंक्टिक एंटीरियर सेक्शन आउट हो जाता है. सो व्हाट रिमेन्स इज APR एंड ELAP. Understand the question first. A 70-year-old male patient with a lax sphincter and a poor continence is diagnosed to have a moderately differentiated adenocarcinoma of rectum, which is 5 cm from the anal verge. That means it is very, very low. CA is 70. MRI shows 2 mm from the circumferential resection margin with suspicious nodes. Patient received neoadjuvant chemoradiotherapy. Post chemoradiotherapy MRI shows a partial response and the intersphincteric plane are free of disease. What is the next line of management? As I said, tumor is 5 cm and there is a poor continence and lax sphincter. So LAR is out, intersphincteric anterior resection is out. What option remains is APR and what is this? Extra levator abdominal resection. So ये दोनों में से आप क्या प्लान करोगे? There's a hint here, intersphincteric plane are free of disease. So in case the intersphincteric plane are free of disease, you will plan only APR. In case the levator is involved, then what comes is extended levator. As the name suggests, extended levator. If the levator is involved, then you even remove the part of levator along with APR. Answer here is APR. Next question, 70-year-old male who had underwent a complete treatment for a CA rectum is on follow. 1 year after completion of treatment, his CA is 30. His physical examination and colonoscopy and everything which is come back to normal. What is the next line of investigation? Stool occult blood, repeat colonoscopy, PET scan and bone scan. What did I tell you? What are the indications of PET scan? Rising CA level post-operatively. So here patient requires a PET scan. Okay, remember two indications of PET scan, rising CA level and in case is an operable liver lesion. Okay. Same question I put here about the liver part. Okay. So they ask you that male had underwent a completed treatment for CA rectum, is on follow-up. 1 year after completion of treatment, his CT and abdomen pelvis showed a single lesion 3 cm in segment 7 of the liver. What is the next plan of action? That means एक छोटा सा ट्यूमर है जो रिसेक्टेबल है. तो ट्यूमर रिसेक्ट करने के पहले आपको देखना है कि ये एक ही ट्यूमर है कि और कोई भी ट्यूमर फैला हुआ है. So that's why you will always plan a PET scan. Okay. So answer here is PET scan. Next question, 65-year-old patient with CA rectum, T3N0 had chemoradiotherapy. MRI done after 8 weeks shows complete CCR means complete clinical response. What should be the further line of management? That means एक patient है जिसको T3N0 disease था. Okay, he had received chemoradiotherapy. MRI was done after that, which shows a complete clinical response. What should be the further line of management? Wait and watch, local excision, TME or all of the above? What should be the next line of management? Everything is possible here. Everything. We can wait and watch also. We can locally access that part also because we are not sure whether the patient is going to come for a follow-up or no. We can even plan for a TME. Here the answer is all of the above. Okay. Some clinical scenarios now what a CA rectum can come as to you in the emergency. So 60-year-old patient presents with obstructed CA rectum 9 cm from the anal verge with M1B disease. That means there is a metastasis, out of which is not an option for treating this patient. Loop transverse colostomy, loop sigmoidostomy, SEMS or a Hartmann's procedure. Obstructed CA rectum है. So definitely he is going to require a diversion. Diversion मतलब ये colostomy आ गया, sigmoidostomy आ गया. What are the other methods of relieving that obstruction apart from this surgical management? SEMS. तो ये तीनों ऑप्शन हम लोग यूज कर सकते हैं. चौथा ऑप्शन जो है हार्टमैन्स प्रोसीजर, दैट मीन रिसेक्ट करके नीचे से एक स्टम्प बनाने का. इज इट फिजिबल व्हेन देयर इज अ डिस्टेंट मेटास्टेसिस? जब भी डिस्टेंट मेटास्टेसिस है तो आपका इतना एक्सरसाइज करके ट्यूमर निकाल के कुछ फायदा होने वाला है? नहीं होने वाला है. सो डेफिनेटली हार्टमैन्स प्रोसीजर इज द ऑप्शन हियर और इज नॉट एन ऑप्शन हियर इन फैक्ट रादर. ओके, मतलब इसमें हम लोग लूप ट्रांसवर्स कोलोस्टोमी भी कर सकते हैं, लूप सिग्मोइडोस्टोमी भी कर सकते हैं जस्ट फॉर डाइवर्जन. ओके, एंड इन केस देयर इज अ फैसिलिटी अवेलेबल, द बेस्ट ऑप्शन हियर, रिमेंबर हियर अगेन, इन केस विच इज नॉट, अगर बेस्ट ऑप्शन पूछते हैं इसमें से तो बेस्ट ऑप्शन इज सेम्स. ओके, CA rectum T3B tumor M06 cm from the anal verge with poor anal tone. Again देखो anal tone आ गया. With no metastasis. Best treatment option is CA rectum T3B 6 cm from the anal verge with poor anal tone. Anal tone है तो आप sphincter surgery करोगे, sphincter preserving करोगे, ultra low AR करोगे, LAR करोगे, नहीं करोगे. बचता क्या है? ये दो ही ऑप्शन बचता है, लो हार्टमैन्स प्रोसीजर एंड APR. APR बेस्ट ट्रीटमेंट ऑप्शन इज हार्टमैन्स प्रोसीजर, नॉट एन APR, क्योंकि इन्होंने क्या लिखा है कि देयर आर नो मेटास्टेसिस. तो आप डायरेक्टली उसको APR करोगे, देयर आर स्टिल चांसेस दैट अ पेशेंट माइट improve a tone post operatively and you can plan for a Hartmann's procedure later on in AR. डायरेक्टली आप रेडिकल सर्जरी करोगे, किसका APR करना अच्छी बात है क्या नहीं है? नहीं है. यू ऑलवेज शुड एक्सप्लोर द अदर ऑप्शन. तो इसमें क्या है, फॉर टाइम बीइंग पुअर एनल टोन 6 सेंटीमीटर फ्रॉम द एनल वॉज. इसमें ऑप्शन क्या आने वाला है आपको, लो हार्टमैन्स और APR. APR we are not planning because still the patient with no metastasis. That means they are written here is the tumor is still operable, the cancer is still operable. The only thing is poor anal tone. That means आप सिर्फ कट करके उसको नीचे छोड़ दो. एक बार पेशेंट का ट्यूमर ऑपरेबल हो जाएगा, पेशेंट स्टेबल हो जाएगा, देन यू अगेन प्लान एंड डू अ सर्जरी. So APR here is not option. The answer here is a Hartmann's procedure. 70-year-old male patient with obstructed CA rectum 8 cm from the anal verge, invading the lateral pelvic wall with multiple liver metastasis. What is the best treatment option available? Loop ileostomy, Hartmann's procedure, SEMS or loop sigmoidostomy. Best treatment they are asked, best possible option available. Loop ileostomy करोगे आप, आपको सीकम के बारे में पता नहीं है, ट्रांसवर्स कॉलम के बारे में पता नहीं है, लूप आइलोस्टोमी करके कुछ मतलब नहीं है, अदरवाइज विल क्रिएट अ क्लोज लूप ऑब्स्ट्रक्शन. ओके, सो दिस इज नॉट एन ऑप्शन. विल डू अ लूप सिग्मोइडोस्टोमी, दे आस्क फॉर द बेस्ट ऑप्शन. ऑब्स्ट्रक्टेड सीए रेक्टम है, सो बेस्ट ऑप्शन इज सेम्स. ओके, सेल्फ एक्सपांडिंग मेटालिक स्टेंट, बिकॉज इसमें लैटरल पेलिकॉज इन्वॉल्व है, मल्टीपल लीवर मेटास्टेसिस इन्वॉल्व है. इसके लिए अगेन डूइंग अ रेडिकल प्रोसीजर of resecting and creating Hartmann's is not feasible. So best option है, जितना आप कम करोगे उतना आपके लिए अच्छा है. और इसमें कम मतलब क्या है, विदाउट सर्जरी सेम्स. ओके, 70-year-old male patient obstructed CA rectum 8 cm from the anal wall, invading lateral pelvic wall, multiple pulmonary. What is the treatment option? ये बताया, हो गया शायद. 8 cm from the anal verge, ये दूसरा है, 8 cm from anal verge वाला है. ठीक है, skip this. 70-year-old curable partially obstructed CA rectum, partially obstructed CA rectum with no proximal bowel dilatation. Best treatment option is ileostomy, SEMS, Hartmann's or neoadjuvant chemoradiotherapy. What? Neoadjuvant chemotherapy, because here remember is partially obstructed, there is no proximal dilatation, so there is no emergency as such. You can always give a try of chemoradiotherapy and wait for the tumor to shrink, and after the tumor has shrunk you can plan for a definitive surgery. So answer here is neoadjuvant chemoradiotherapy. Important concept, that means after you have done a APR, there are ways to find out whether you have done a good APR, a moderate APR or a bad APR, depending upon the kind of specimen you had resected. Okay, so what they have asked here is post-operative specimen of CA rectum shows exposed muscularis propria and gross appearance. What is the grade of TME? Poor, definitely. What do you mean by good TME? That means the distal lid is not cone shaped, it's little bit wide base, a good chunk of mesorectum involved and no muscularis propria, or even if it is seen, it is less than 1 millimeter. So that is a good TME. Moderate TME is muscularis propria is seen, but is seen only at the pelvic floor. Okay, moderate bulk of mesorectum. Okay, so that is a moderate TME. Poor TME is no absolute bulk of mesorectum, cone shaped, the shape of that particular specimen, and absolutely shattered muscular propria which is seen. That is a bad TME. So you should understand this basic concept of good TME, moderate TME and poor TME. Okay, this question can be asked. These are the different specimen of, they might show you this one of the specimen of poor surgery which shows a little mesorectum, absolute bad shape of this particular specimen what they have taken out. Average surgery, incomplete removal, and excellent surgery. We can see a wide base, there is no coning here, it is a good specimen. Then come to an early malignancy of CA rectum. Okay, so we are done with everything now. Now we are coming with actual management of surgical management of CA rectum. So we go phase by phase. We'll talk about small tumors first. When I'm talking about small tumor first, that means we are talking about a polyp, a malignancy in polyp. Now the polyp can be of two types. It could be a pedunculated polyp and it could be a sessile polyp. Okay. This is a pedunculated polyp. Classification, remember this, Haggett's classification. Depending upon the level of invasion of submucosa, whether it's involving only the head, neck, stalk or beyond the stalk, we label that as level 1, 2, 3 and 4. If it is involving only level 1, 2 and 3, your transanal excision is more than enough. But moment it goes into submucosa here beyond the stalk, it requires more than transanal excision, and what is more than transanal excision is TME or AR. समझा नहीं समझा? सबसे छोटा सर्जरी जो हम लोग करते हैं सीए रेक्टम में वो है ट्रांसएनल एक्सिशन, उतना एक्सरसाइज करके दैट्स ऑल. ओके, बट डज दिस व्हेन विल दिस पेशेंट फिट इनटू a transanal excision category or a TME category? It is if it is involving only this level 3, 1 to 3, will plan for a transanal excision. But moment that polyp what you are removed has extended into level 4, which is seen on histopathology, you convert that transanal excision into a TME. समझा नहीं समझा? Okay, so this is the management of a pedunculated polyp. The classification, remember this name, Haggett's classification. Okay, so for level 1 to 3, the risk of lymph node spread is only 1%. That's why your transanal excision is suffice. But moment it goes beyond that, patient will require a TME. इतना सब basic चीज याद रखो, ठीक है? In case is a sessile polyp, not a pedunculated polyp, but a sessile polyp, we got a classification called as a Kikuchi's classification. Okay, इसमें भी ग्रेडिंग रहता है कीकुची में भी. If the submucosa, SM means submucosa 1 is involved, that means it shows the invasion of a tumor into submucosa which is only 1 millimeter. Submucosa 3, that means invasion into the submucosa which has reached up to the musculus propria, and 2 is basically between 1 and 3. इसमें क्या है, same thing what we manage for a transanal excision for a pedunculated polyp. Level 3 तक हम लोग transanal exercise करते थे, उसके बियॉन्ड वी आर प्लानिंग फॉर TME. इस पे भी सेम रूल अप्लाई, बट हियर में क्या है, SM1 और SM2 अगर इन्वॉल्व है तो ट्रांसएनल एक्सक्लूजन इज सफाइस. यहाँ पे अगर SM3 है, पेशेंट रिक्वायर्स TME. अंडरस्टूड दिस सिंपल कंसेप्ट ऑफ अर्ली मैनेजमेंट, अर्ली सर्जिकल मैनेजमेंट ऑफ रेक्टल कैंसर डिपेंड्स अपॉन व्हाट लेवल ऑफ इन्वेजन इज देयर. ओके, तो पहला उसको कैटेगराइज करना है, पेडुंकुलेटेड पॉलिप है क्या ससाइल पॉलिप है, उसमें भी ये कौन सा लेवल है, लेवल 1, 2, 3 इन केस ए पेडुंकुलेटेड पॉलिप, इन केस इज अ ससाइल पॉलिप SM1, 2 and 3. So we'll take questions on this now. Which is not true regarding local resection of rectal malignancy? Is appropriate for all T1 tumors? It is appropriate for tumors which are less than 6 cm from the anal verge. Is done when there is no lymphovascular invasion, and trans and endoscopic microscopic surgery is done for high rectal tumors. We'll finish at 3:15. 3:15 to 3:40 we'll take a break, 30. So whatever MCQs I am able to finish up till 3:15, we'll finish it up. Okay. Okay. So what is the answer here? Which is not true regarding local resection of rectal malignancy? Appropriate for all T1 tumors. Appropriate for tumors less than 6 cm. Done when there is no lymphovascular invasion. Transanal endoscopic microscopic surgery is done for high rectal tumor. That means here they are asked, what are the indications of transanal excision? Are these two the indication of transanal excision? Yes. Though lymphovascular invasion is one criteria to define, patient can undergo a transanal excision. Tumor which are less than 6 cm from the anal verge, yes, again this is the criteria, because if the tumor is very high, you can't do a transanal excision. The tumor has to be lower in the mid or the lower rectum, then only you can plan for a transanal excision. Is it appropriate for all T1 tumors? No. There are certain defined criteria even on histology which categorize the patient that he is going to require a transanal excision or a TME. So it has to be a well or a moderately differentiated adenocarcinoma. Okay, so these are the only, T1 में भी आपको बताया था कौन सा T1 है, हैगिट्स में और ये इसमें, ठीक है. सो ऑल नॉट T1 कैटेगरीज meets the criteria of transnasal excision. There are certain groups which meets the criteria. So this is the answer here. Is appropriate for all T1 tumor. This is the false statement. So what is the criteria here? That means what is the indications of local excision? If the tumor is involving less than 30% circumference, why less than 30%? क्योंकि अगर more than 30% रहेगा और अगर आप उसको एक्सेस करके क्लोज करने के लिए जाओगे, so patient will end up with stricture. Okay, so the circumference has to be less than 30 centimeter, 30%. Size should be less than 3 centimeter. It should be having a clear margin of more than 3 millimeter. Mobile and non-fixed. How do you know whether it's mobile or not fixed? Basically, it indirectly gives a hint. That means it is not involving the submucosa. Moment it involves the submucosa, that means patient is going to require a TME. Within 8 centimeter of anal void, that means it has to be accessible. अगर ऊपर रहेगा तो आप कहाँ से ट्रांसएनल एक्सिशन करोगे? T1 only. Endoscopically removed polyp with indeterminate pathology. No lymphovascular invasion, moderately differentiated, full thickness excision feasible. What are the different types of local excisions we can plan? Something called a transnasal excision, मतलब open surgery जिसको बोलते हैं. Just spread the buttocks, use a proctoscope, and whatever tumor you see, just access that with your regular artery forceps, with your cautery. So that's a simple transanal excision. Okay. If we are using a specific instrument, then it becomes a, this is a transanal excision. This is a transanal endoscopic microscopic surgery. Okay, here we are using an endoscope. So this is called as a transanal endoscopic microsurgery or TEMS. Here tumor अगर काफी अंदर भी रहेगा, transanal से क्या होता है? That means we are by naked eye using the proctoscope, we are just removing the tumor. तो ज़्यादा से ज़्यादा हम लोग कितना नहीं, प्रोक्टोस्कोप आपने आपको बताया था कितना एंट्री देगा 8 सेंटीमीटर तक. लेकिन समझो अगर आपका ट्यूमर मिड रेक्टम में रहेगा तो उसके लिए क्या अच्छा है? एंडोस्कोप इज मच बेटर. एटलीस्ट इट गिव्स अ लिटिल हायर डेप्थ फॉर यू टू ऑपरेट, लिटिल हायर यू कैन ऑपरेट. ओके, सो दिस इज ट्रांसएनल एंडोस्कोपिक माइक्रोस्कोपिक सर्जरी. द ओनली डिसएडवांटेज हियर इज इट इज कॉस्टली बिकॉज इट इन्वॉल्व्स अ स्पेसिफिक इंस्ट्रूमेंट्स, सो इट इज कॉस्टली. फिर अदर ऑप्शन इज जैसे हम लोग लैप्रोस्कोपिक सर्जरी करते हैं वैसा यूज अ पोर्ट. सो दैट दिस इज कॉल्ड एज अ ट्रांसएनल मिनिमल इन्वेजिव सर्जरी, TAMIS. So remember these three basic methodologies of locally excising the tumor: transanal excision, transanal endoscopic microscopic surgery, and transanal minimal incision surgery. This I had given in your notes. What is the feature of transanal excision, TEM and TAMIS? Remember, the only feature is because of TEM and TAMIS we are able to assess the tumor which are even 15 centimeter from the anal verge. Remember this basic difference feature. Okay. Surveillance, nothing significant in this. In case you happen to perforate the bowel while doing a transanal excision, what are the options available? You can do a laparoscopic suturing of rent. Transanal suturing of rent is not possible because anyway for transanal excision we are insufflating the air. Moment there is a perforation, there will be desufflation. You won't be able to see. So here transanal suturing is not an available option. Abandoned procedure certainly not. Diverting colostomy for an electively prepared bowel, you can't do a colostomy. So best option here is laparoscopic suturing of the rent. Which of the following is not the indication for TME after local excision? Kikuchi SM3, fragmented polyp, positive resection margin, T2N0 responding to neoadjuvant chemotherapy. That means they are asked you about the indication of local excision. That means indication of TME after local excision. That means you have done a local excision, okay? You have sent a sample for histopathology. Now what are the basis or what are the criteria which will decide कि ये भाई लोकल एक्सिशन से काम नहीं चलने वाला है, पेशेंट को TME ही लगेगा. सो व्हाट आर दोस फैक्टर्स? इज दिस द फैक्टर? यस, डेफिनेटली, बिकॉज एज आई सेड SM3 सबम्यूकोसा लेवल 3 इन्वॉल्व है तो इसको TME लगेगा. फ्रैगमेंटेड पॉलिप, यस, बिकॉज वी आर नॉट श्योर वेदर मार्जिन्स आर फ्री और नो, सो अगेन उसको भी TME लगेगा. पॉजिटिव रिसेक्शन मार्जिन, डेफिनेटली इसको भी TME लगेगा. द आंसर हियर इज T2N0 which has responded. In case it has not responded, then definitely TME, but here T2N0 which is responding to neoadjuvant chemotherapy is the option. So We have defined the criteria for local excision. What shows here is excision करने के बाद where your excisions are not going to suffice, you are going to require a teaming. So what are the indications? आपको समझा ये क्या है slide? After excision, what are the factors that will decide patient is going to require a major surgery? So these are the factors: Haggett level 4, Kikuchi SM3, angiolymphatic invasion, PT2, poorly differentiated tumor, positive margins, fragmented polyp, excessive use of cautery, and a grade 3 and grade 4 adenoma. Okay. Just to give an overview of what are the different surgical options which are available for CA rectum. In case of sphincter saving surgery, we have AR, low AR, ultra low AR, and intersphincteric AR. AR means the anastomosis is above the peritoneum. Low AR means anastomosis is below the peritoneum. Ultra low AR, that means it is at the level of pelvic floor, and intersphincteric means it is below the pelvic floor. समझा नहीं समझा? Depending upon level of your anastomosis, these are different categories of anterior resections what are available to you. Anterior resection, anastomosis is above the peritoneal reflection. That means very high tumor. We do an AR. Low AR, anastomosis is below the peritoneal reflection. Ultra low AR, your anastomosis is at the level of pelvic floor, at the levator. Intersphincteric is below the levator. The only difference is this particular 3, we can do a stapler anastomosis. But when it comes to intersphincteric, it's better to do a hand sewn. And in this case, apart from being hand sewn, it's better to do a diverting stoma, because the chance of leak is very high in intersphincteric AR as compared to all these 3. Understood? ये basic concept आपको सिर्फ याद रखना है, बाकी कुछ नहीं है. ठीक है? Sphincter खराब है, अगर sphincter involved है, or if the tumor is low, what are the options available for you? APR. In case the levator are involved, you do an extended levator, abdominal perineal excision, APR plus pelvic exentration. That means in case the surrounding organs are also involved. Okay. So dictum, tumor which is just 6 cm above from the anal verge, we do an AR. Tumor which is 6 cm below the anal verge, we do an APR. This was done initially where जहाँ पे ट्यूमर है वहीं से सिर्फ 5 सेंटीमीटर मार्जिन नीचे आप मीजोरेक्टम निकालते थे, ये इतना मीजोरेक्टम छोड़ देते थे. बट अभी ऐसा नहीं होता है, हम लोग ये पूरा ही टोटल मीजोरेक्टल एक्सिशन, दैट मीन्स वॉट एवर मीजोरेक्टम इज देयर सराउंडिंग द रेक्टम, वी रिमूव दैट विल कॉल्ड एज अ टोटल मीजोरेक्टल एक्सिशन. दिस इज टोटल मीजोरेक्टल एक्सिशन. ट्यूमर स्पेसिफिक मतलब दिस इज ट्यूमर स्पेसिफिक. यहाँ का ट्यूमर है 5 सेंटीमीटर नीचे, आपने ये जो मीजोरेक्टम है उसको निकाला है, दैट इज कॉल्ड एज अ ट्यूमर स्पेसिफिक TME. टोटल मीजोरेक्टल मतलब कंप्लीट मीजोरेक्टम निकाला है. ठीक है, दिस इज स्टैंडर्ड TME, दैट्स व्हाट आई सेड. हाई टाई, लो टाई is not important for you, that means it's very standard questions for that. As I said, in case is a colorectal anastomosis, usually suturing method is by hand sewn. Okay, upper रहेगा, colorectal रहेगा, best option is circular stapler. Complications of LAR: high bowel frequency, urgency, soiling, inability to defer defecation up for 15 minutes. For that, in case you want to prevent all this complication, better to create some kind of pouch, J pouch, W pouch or S pouch. APR, types of APR: standard APR where we have a cone shaped, we remain close to levator, don't excise the levator and create a cone of mesorectum and the rectal specimen. Extra levator, in case the levator is involved, we take a chunk of levator also in that. So here it's not cone shape, it is basically a cylinder shape. Okay, so that's why it is also called as a cylinder APR. Okay. Types of sacral resection: type 1 is low sacral amputation, that means below S2 S3. Below this, in case it is involved, below this is S2 S3 or type 1 amputation. Type 2 is below S1. Type 3 is you remove the entire sacrum. Type 4 is apart from sacrum you remove even the L5. Just understand different kind of surgeries what are available for CA rectum, nothing else. Trials, as I said, Mercury trial is to be understood, Stockholm trial has to be understood, color, classic, Korean, basically they all say that laparoscopy, advantage of laparoscopy and an open surgery are almost same. The only advantage with laparoscopy is the recovery is faster. So that all this particular trial says, color trial, classic trial or Korean trial, remember this. So these are trials you should remember as far as CA rectums are concerned. Okay. Now these are different questions which are available or this can be asked as far as their anatomies are concerned. Okay. Support to the fecal material, transverse rectal folds. ये क्वेश्चन था जो आपको मैं बार बार बोल रहा था, pelvic splanchnies are primarily carry preganglionic parasympathetic. I think we'll just stop on here because now the anal canal will start. I think it's too difficult to cover now. Maybe once we get some time, after that we'll cover. Okay. Any questions till now? And everything what is there on the slide is been provided to you, will be given to you. Okay, so don't bother about that. It's all theory. Now, basically, I discussed the clinical part, ifs and buts. That is more important for you to understand. These are all theory. Even if you go back home, you can understand that. So there's nothing to be explained in that. Okay, so we'll I think just stop on here. Anal canal is remaining, but again, it's not a huge topic, just a small topic. If I need to summarize the entire anal canal, just remember two things in anal canal. One, what they ask is the Negro regimen. Negro regimen, which is very, very important, that is chemoradiotherapy. That means they give one shot of 5-fluorouracil, radiotherapy and mitomycin, followed by radiotherapy. Okay, so as far as the anal canal is concerned, Negro regimen is very important. Second thing is differential diagnosis as far as CA anal canal is concerned. Need to learn about melanoma, basal cell carcinoma, Buschke-Leventine's tumor, Lewis-Stein's tumor, what they call, or a verrucous carcinoma. So remember these two important basic things as far as the anal canal is concerned. Rest all things are not important as far as your clinical presentation or clinical importance is concerned or MCQs are concerned. Okay. Any question? Should we break? Okay.
Organizing this session and B for conducting this session as a part of the KEMSS prep course. So I request Alan and Sana to please felicitate sir.